I'm Aaron Kramer. I'm the President and CEO of BSR, and delighted that you're here with us today to focus on a topic that could not be more important or more timely: investing in health equity. One bit of a disclaimer: I'm sure COVID-19 will be part of the discussion, but it's not the only part of the discussion. Health equity was a crucial issue before COVID arrived, and as COVID fades, as we hope it will, ultimately, we will still be dealing with chronic health issues as well as other infectious diseases and acute disease. So just to frame things a little bit. This topic is on the agenda with us as part of the forum's growing commitment in looking at health equity and access. The forum launched last September the Global Health Equity Network, which is designed to raise awareness, build collaboration, and spark action to increase health equity, which is one of the major determinants of human well-being around the world. So I'm delighted that you're here. We've got an amazing panel, which I will introduce in just a moment. The way we're going to go today is in just a moment, we're going to hear from the President of Malawi. We'll then have some Q&A with our speakers here, who represent a diverse array of backgrounds and institutional affiliations and perspectives, and then we'll open it up for questions and hopefully debate and dialogue with all of you. So without further ado, let me introduce the Honorable Lazarus McCarthy Chakwara, who is the President of Malawi. We are delighted you can join us, and please, we'd love to hear your thoughts.
Your Excellencies, distinguished guests, ladies and gentlemen, in the conventional thinking of the pre-COVID world, what mostly behaved as though what makes a nation's economy thrive is economic activity, the making of things of value to be sold and brought to a profit, and in turn, the making of profits to be invested in the creation and expansion of industry across multiple sectors. But that world has come crashing, and the convention is gone. And so COVID-19 has completely debunked this assumption. We now know that public health is the bedrock of economics. We are now painfully aware that if the health of any nation's citizens cannot be guaranteed, it threatens the very foundations of that nation's economy. We are also painfully aware that the economies of all nations are so inextricably linked that a coronavirus outbreak in the Eastern world or a monkeypox outbreak in the Western world can have devastating effects on economies in the global South, where I come from. And for this reason, the only way to safeguard the global economy from the kind of health-related disruptions we have experienced in the past 2 years is to ensure that there is equitable health care across the globe. In practice, this means that investing in filling the health system's gaps and inequities that the pandemic has exposed in developing nations like Malawi is an investment in the stability of the global economy. It must be done, and it must be done by all stakeholders. One model for doing this is that is worth highlighting is the Global Fund, whose seventh replenishment I am a champion of, and investments in health systems by the Global Fund have given our health facilities the capacity to save millions of lives from malaria, which is the #1 killer in Africa, as well as tuberculosis, HIV, and AIDS. So my appeal to you all is to make sure that the initiatives like this that are aimed at investing in health systems do not lose their place on your list of priorities. Because the loss of investments in health is not merely a fear, but a reality that critical players like the Global Fund are having to contend with, as contributing nations are reassigning their resources to emerging geopolitical emergencies like the war in Eastern Europe right now. However, if the experience we have, which is all of us have had with COVID in the past 2 years, is anything to go by, this is not a gamble we can afford. We must deal with security emergencies without compromising investments in public health, because the future of our economies depends on it. Thank you for your attention.
Thank you, Mr. President, for joining us. We know you have a very busy schedule, of course, and I think where you ended is worth underlining. We cannot be diverted from our long-term challenges no matter what the immediate headlines are. Headlines and history are two different things, and we need to stay focused on building the right kind of history despite the horrible headlines that we're seeing so often. So thank you very much for kicking us off. Let me introduce our panelists to you, and I'm going to go from my left in this direction. Tolu Oni, and you've got the longest title of anyone here, so I'm gonna read it because I want to make sure I get it right. So you are the director of the Global Diet and Activity Research Group and Network, the MRC Epidemiology Unit at the University of Cambridge in the UK. I have a friend who's an epidemiologist. He said the only good thing to come from COVID is people know how to pronounce what I do now. So there's that. Mats Krogsgaard Thompson is the CEO of the Novo Nordisk Foundation, a grant-making foundation that also is a majority shareholder of Novozymes and Novo Nordisk, two companies. Very interesting model. And Caroline Anstey, PACT, a great global NGO. And to my immediate left, Puneet Ranjan, who is the global CEO of Deloitte, which I think you've probably heard of before. So, Tolu, let me start with you, and maybe you can set the scene for us a little bit. So, give us your perspective, working on these issues for a long time, living in the UK, but being from Africa. As an expert, give us a sense of the overall picture of health equity and access right now. Are there things that are working well? Where are the biggest issues that we need to focus our attention?
Thank you, and I agree with your assessment of the epidemiology. I would add to that people also now know what epidemiology is, and they don't think it's just a skin doctor, because that was what I used to get. So how I'm going to frame this actually is around health, and I'm really grateful to His Excellency for framing it in that way. I'm a public health physician, and so one of my main missions is to highlight the distinction between health and healthcare. We know that over 80% of factors that influence health lie outside of the healthcare sector. And yet when we talk about protecting and maintaining health, we almost entirely talk about the healthcare. Healthcare is absolutely critical, and we need greater and universal access to that. But particularly on my continent, and I'm Nigerian, but I lived a long time in South Africa, when we have a median age of 19, when we're talking about protecting health, first and foremost should be about protecting health and preventing disease. There's nothing inevitable about having a stroke at 35 because you have uncontrolled high blood pressure from exposure to air pollution and from unhealthy food environment. That is a design fault of our environmental exposures. And so if we think about it in that way, we flip our thinking completely. So when I think about inequity, I think about 4 dimensions of inequity. I think about inequity with respect to exposure, with respect to susceptibility, with respect to access, and with respect to consequence. So exposure in terms of who is exposed. We learned from COVID in terms of the exposure to the risk of disease was not equally distributed across the population. We know from air pollution that whilst not over 90% of the world breathes air that doesn't meet the WHO standards, we know that the distribution of clean air is unequally distributed with a higher exposure to air pollution, with a higher exposure to unhealthy food environment in lower socioeconomic contexts. And that is even within cities or within countries, not to talk about between countries. So that's a really critical. Susceptibility, we have to recognize that one of the key, when we think about these upstream determinants, they can cause disease through directly causing disease, like I mentioned, the risk of air pollution, cardiovascular disease. Whoa, okay. I read an interesting study, I'm just going to say that before I go to susceptibility, that I thought was really striking. There was a study that was done in the US that looked at heart attacks over a 1.5 year period before and after COVID, and found that in parts of the US that had significant drops in air pollution because of the lockdowns, they had a significant decrease in heart attacks. This is, I'm not talking about a long-term thing. This is between looking before the pandemic and looking in the first few months of the pandemic. Somehow we don't see this. So in terms of susceptibility, it also makes existing diseases worse. So if we talk about who is vulnerable, we know that things like air pollution, particularly in younger populations, is really critical. There was a study done in Lagos by the World Bank. That looked at air pollution, the cost of air pollution in Lagos alone in 1 year lost at 2% of its GDP. It found that of the air pollution deaths, 60% of the air pollution deaths were in under 5s. When we talk about health equity, this is where we need to start. We know that in India, there's examples of diabetes being worsened by exposure to air pollution. These are connections we don't actually, not obvious to make. In terms of access, the third dimension of equity, access to care, absolutely critical, and we see the difference between rural and urban. Within urban, we see the difference in spatial equity, but also access to information and reliable sources of information. So this is part of the healthcare system that is often neglected. Who has access to the right information? And lastly, consequence. So if you're sick, what happens to you? Right. So, if are you at risk of losing your job? Are you at risk of your family going hungry? So there's inequity with respect to consequence of ill health as well.
Thank you, Tolu. I'm glad you mentioned that this is a question both within and between countries, crucial point, and the focus on pollution that you gave is really important. It's a reminder that climate action is a major public health mechanism that that can help us to make great progress. Mats, let me turn to you, and certainly in the last couple of years there's been a sharp focus on what the public sector is doing to advance health equity and access. From your perspective, leading a foundation that's linked to a couple of businesses, what is the role of business? What is the role of philanthropy in catalyzing improvements in public health?
Yeah, thanks, Aaron. First of all, I'd like to mention that COVID-19 has done some good things, including an enhanced understanding of the need for true public-private partnerships, including in the health area. And just to reflect on something you started by saying, yeah, it is actually so that infectious disease can impact non-communicable chronic disease and vice versa. So during COVID-19 in the US, those who had diabetes had a greatly increased, or obesity, greatly increased likelihood not only of getting morbid from COVID, but also dying from COVID. And as you also mentioned in India, if you take the situation of a person with diabetes, of whom there are 87 million, their likelihood of having a bad outcome of tuberculosis is greatly increased because of the impact on the immune system. So I fully agree that the climate system, pollution, the infectious disease area and the NCD area, they are so closely interwoven. I'll mostly speak to chronic diseases, cardiometabolic diseases. I would, however, emphasize that there are also clear health inequities when we look at things like antimicrobial resistance. The biggest use of antibiotics in livestock production and so on is actually in low and middle income countries, and they are also those henceforth who are at greatest risk of AMR problems and who have access to the fewest tools to combat those problems. So as a foundation, we're working very much on trying to combat that situation, both by advice but also by new tools, new antibiotics and so on. And the vaccine situation, I think we don't need to dwell on because we all know that. I'd rather talk a little bit about cardiometabolic disease, which I perceive to be a continuum that starts with childhood obesity, leading to type 2 diabetes, cardiovascular disease, renal disease, fatty liver disease, and so on and so forth. And there we have a situation where all the studies that have been done today characterizing these diseases, 90% are done on Caucasians. But 80% of them live in low and middle income countries in Asia, Africa, South America, and elsewhere. So there we have to, first of all, understand much more about those diseases in those countries. And we're setting out, hopefully in a partnership with many of you, to do a major effort to understand these diseases in those countries where the populations are, so that we can intervene and prevent them in a better way going forward. Because I fully agree that prevention is the way forward. Once an obese person has become diabetic and got one or two comorbidities, you're kind of doomed, in particular in some of these countries. So we're working on creating centers that seek to prevent that a child starts the life at age 3 to 5 to 7 to 10 in such a unfortunate way, socioeconomically, driven by the family tradition of unhealthy foods, lack of exercise, all the things that you know a lot about, that we set out on a nationwide basis to combat that from the preschool age and onwards. And if this multifactorial model will work, which I think it will because we're creating evidence behind everything we do, it's something that we will seek to export to other countries. Initially, collaborators in the UK, but it could be, in principle, in many, many countries. And when I look at diabetes, which I will take as my last example, we know from traveling in India, for instance, for the last 30 years, that in many of these countries, also in Africa, by the way, we've seen such an aggravation of diabetes that is now on the top 5 list of killers. And we know that when you don't have a well-developed healthcare system, as for instance Denmark has, there is so great health inequity in that you are not even getting diagnosed. And without diagnosis, and even the health community workers who are in the rural areas and in the slum areas of the cities, they are not well educated. They know about malnutrition, maternity health, infectious disease, vitamin D deficiency and so on, but they do not know enough about how to diagnose, let alone treat diabetes. So there we will make significant projects in countries both in Africa, in India and so on, to actually combat that health inequity, ideally by creating earlier diagnosis and hence less comorbidities, because as we all know, it's the last 20% of your life with comorbidities that cost 80% of the health cost.
Thank you, Mats. And both Mats and Tolle, you've spoken about the holistic nature, both of the challenge, but of course that also means the interventions within the system can lead to much better outcomes. And that leads me, Puneet, a question for you, because you've been quite vocal about the need for the private sector to address these kinds of questions, including the structural flaws and structural biases that are leading to, shall we say, suboptimal, you could also say tragic, outcomes. What is it that you think the business community can do and should do?
First, I think the two of you did a fabulous job in a very eloquent way laying out the problem. I'm going to make 3 points. First, business has a role, a critical role, and I'll explain why. Second, public-private partnership, as you suggested, is the answer. And third, at least in our experience, that you can actually come up with creative solutions that are not very dollar-intensive to get to some fabulous outcomes. Let me take the first example as to why business. I run an organization that has 400,000 professionals. 86% of them are millennials and Gen Zs. We're a purpose-driven organization. And we say that our purpose is to make our clients successful, take care of our people, and give back to our communities. When I survey my 86% millennial population, they tell me that the number one issue for them is what does Deloitte do beyond its core profit motive? So think about that for a minute. As the CEO for 400,000 person organization, if I don't have a credible response for these people, I am not going to be able to retain them. I will hire 70,000 people this year, or we will hire 70,000 people. One of the funnest things I do is speak on college campuses. Invariably, in the United States, elsewhere, I'm asked, what does Deloitte do beyond its core profit motive? This is not only the right thing to do, it is the right business thing to do. That is why, for us, it was really important to address this issue within the organization. Mental health is one area that we are investing heavily in, but also invest in our communities. COVID, you told us not to speak a lot about COVID, but I want to give an example. So of the 400,000 professionals, 90,000 are in India. When the Delta wave hit in India, nearly every one of my 90,000 professionals was impacted either directly or indirectly. My mother, 82 years old, lives in India. She got COVID. And when you're sitting in the United States, you have to think about how you will respond. And we needed to respond not only to take care of our people, but also to then demonstrate to them that we're living our purpose. So what did we do? We formed a public-private partnership with the government of India, with the Public Health Foundation of India, and with a couple of medical colleges, and came up with a response that leveraged digital technology, virtual health, the local ASHA workers, and treated 96% of the patients at home. Pretty creative. My team was jazzed about coming up with this answer. Mortality rates went down 50% in the districts that we helped. We then took the model and we have distributed it to all 700 districts in India. And we're now applying it towards maternal health. Your point is a very good one around, starting, and I'm not a doctor, and you have such fabulous knowledge, but it's an aha moment for me that 1 million kids in India below the age of 1 die because they're anemic. And they don't have access to health. So this virtual health model that we put together gives them access, one of the 4 items that you talked about. So I think business has a critical role to play. It's in their interest, like I just explained to you why it is in my interest. And second, public-private partnerships like we formed in India are the way to go. And these are not expensive. We put in money, but it's manageable amounts of money to come to outcomes that are pretty exceptional. And I tell you, the impact that it has on my people is out of this world. They love it.
Thank you, Puneet. And I'm going to turn to Caroline, but prompt after we hear from Caroline, would love to open it up to anyone. Oh, we're going to hear from Caroline first, but then you go first after that. So Caroline, let's bring it back to the affected communities that are often excluded, marginalized, and just not reached by healthcare systems. In your work at PACT, what do you see as some of the key mechanisms to try to make sure that the people who are the intended beneficiaries of this discussion are actually benefited?
Thank you, Aaron. Before I do that, and I know you said we shouldn't talk about COVID.
I said not that much, is what I said.
But I did want to build on what the president of Malawi said. He said public health is the bedrock of economies. And we now know that. We've learned that because of COVID. And we have learned that on one level, but our systems haven't adjusted to that. So I think if we thought that health inequity was bad before COVID, it's going to get worse. There are something like 80 countries in the world that pay more in debt service than they're able to spend on their health services. We now see countries plagued by rising prices of food, rising prices of fuel, rising prices of fertilizer. Unless people step in to protect health spending and to grow health spending, all those fiscal constraints are not going to allow governments to do it. So that brings up the question of the role for business. And I agree absolutely on your role for business, but we talk a lot here at Davos about ESG, environment, social governance, tracking it, business, having sustainability reports. The S of social is the poor relation. We haven't focused on that, and we must. And how does that relate to the communities? So that is the bad news of the world we live in. But there is good news. And I think COVID has strengthened health delivery systems at the local level. And that is something we have to play on. Community systems need to be strengthened. The world and government has spent a long time strengthening health systems at the ministry level. It now has to move to the community level so that maternal health can be delivered at the community level, immunizations at the community level, health education at the community level. And that means education of community workers, empowerment of community workers, and a lot of focus on community delivery. And the other good thing that, in a sense, has come out of COVID is that we're all talking about localization now. Trust in the communities, as opposed to perhaps trust in big institutions, has grown. So I think the options for delivering at the community level are there. But there are still marginalized groups. We work on a lot of PEPFAR programs for HIV/AIDS, especially with orphans and vulnerable children and teenage girls. And that disease required dedicated funds from PEPFAR to attack it. We may need to think again about dedicated funds. But what we basically see, what we basically see is that marginalized groups that are affected by stigma, have to be specially targeted. And that means employing means and ways of doing it that relate to those publics. I just want to say something else about business. A lot of discussion in Davos about supply chains. We have to have business take greater responsibility for health all along their supply chain. And the boardrooms have to be involved in that. We talk a lot about last mile populations. How do we get vaccines to the smallest community? But these are also first mile. These are people who are artisanal miners delivering cobalt for all the batteries we use. They're right at the beginning of the supply chain, or agricultural workers. That first mile has to be attended to by business. And I'm seeing some interesting partnerships with local government. And I think it's really critical that when business acts, it acts in tandem with local government and central government. Doesn't have to put its money through the government. I know many don't want to. But if there is not a relationship between what the private sector is doing to a national development plan, you get pockets of wonderful health delivery amid an ocean of deprivation.
By the way, I agree with everything you're saying. I think absolutely it's that type of cooperation that is required. That's what we learned in what we did in our COVID response. Yeah.
So COVID has some really important lessons.
Well, and if we don't learn them, shame on us, because because things that should have been known have been revealed, and things that we knew have proven to be fairly devastating. The supply chain point is really important. One of the reasons why supply chains are often populated by women workers who don't have access to formal healthcare systems, and migrants for whom the same thing can be said. So they represent some of the most vulnerable populations. Great kickoff here. I've got one question there, and then from my friend Mo. Okay, this is great. We've got 4 questions. So if I can ask you to ask a question, introduce yourself, and be as brief as possible.
So good morning. Thank you for having me. I'm Camilo from Global Shapers Community. I have 2 questions. First, how we can have more transparency and use data from public and private sector to improve health equity. And back to you to mental health, suicide is huge for the youth population. So how we can make mental health priority, not for the big companies, but for the small business. Like we don't talk about mental health in the small business, and they had more of the employees. Thank you so much.
Thank you. So maybe ask one or two people to respond to each question so we can get as many in as possible. So, all right, Mats and Tolu, so both data and mental health.
Yeah, I'll take a bit on the data part. There's no doubt, and again, we learned that about epidemic surveillance of COVID-19, that there's a huge problem there, both in getting connectivity between different zones of the world and even having data. The way we are looking at it is if we do something, let's say in Africa, to better understand chronic diseases, we will of course make sure that the data are on servers that are locally placed in that continent, but where you can have federated data and where scientists can actually access them across the globe after a certain search mode and so on. Because I think we have many health data, and in many countries like India, for instance, we're witnessing a situation that because of the digital strategy, health strategy of India, it will actually become possible for people very remotely to be able to access their health data, and we can do things with e-learning and so on, and telemedicine that we thought were totally impossible before COVID-19. But data access is absolutely crucial.
Totally.
And I'll just build on that because I will keep pulling us back to the intersectorality. One of my maxims for health equity is that health does not trickle down from good intentions. The reality is that we think it does. And part of the reason is that we have disease data, let's call it what it is, and we have health data in terms of the environments I speak about. They're siloed in different sectors. If we wanted to know what the impact of a new urban development and infrastructure project was on hospital admissions in children under 5 of asthma, we don't have those. Those data exist in different sectors and in different ways. They may not be collected in interoperable ways, but we can't. How do we know we're doing good? How do we know we're not doing harm? In a really complex adaptive system, you cannot assume that something that sounds like is a good idea is actually a good idea. So we talk some of the work that I do is looking at putting health at the heart of climate action. We've got a commission looking at what the health impacts of some of the mitigation climate actions are globally. We looked across, there is such little data because nobody is measuring it, right? So one of the things I talk about when we talk about surveillance is that we actually, if we're talking about comprehensive health surveillance, we should be thinking about integrated surveillance that integrates disease data from the healthcare sector with data from the housing sector, with data from urban planning sector, with data from the transport sector. There was a study conducted in Wales where they looked at the impact of upgrading social housing in terms of ventilation, of lighting, of thermal comfort over a 10-year period. And they found that in people who resided in those upgraded houses over a 10-year period, reduced hospital admissions, emergency hospital admissions, by 40% over 10 years. If that was a pill, we'd all be, we know what to do, but the amount of work it takes to bring those data together is absolutely critical. And this is why public-private is so critical, because a lot of those data do not sit in the public sector. So it's not the public sector building cities, right? Who is funding the building of cities? Who is shaping the design of cities? It's not the public sector in a lot of the cities I work in. So it's really critical that that public-private partnership is there to share the data and integrate the data, and also to have a commitment to saying, so if we're saying we're committed to looking at our health impacts across the value chain, we have to be able to measure that, and data is really critical.
Thank you for that. And does anyone want to take on the mental health and well-being question?
What was the...
Do you want to quickly repeat the question? Yeah.
I was talking about like suicide. Suicide has been increasing, especially for youth. And so how we can make mental health priority, not just for the big companies, but also for small and medium business.
Anyone want to take that question? Undeniably crucial point.
I can start one small notion. we've come to realize that among young people post-COVID-19, there are many more acute mental health crises that manifest in different ways, self-injury, suicide, whatnot. And we actually believe that we should focus on that so much that you can't just have them come to a standard emergency ward where they're together with people with broken legs and alcohol problems, whatever. We actually need to focus on them per se and create clinics where they, with their families, are able to receive initial care and then, of course, care following that to deal with the problem at stake. But as such, we're not so much into mental health.
Yeah, I mean, I'll take that on, but I don't have a response or a good response to the medium and small enterprises. But at Deloitte, I mean, what we've tried to do is destigmatize this and to have an open discussion about mental health and put resources behind it for our professionals and make it available. It's been really important. It has COVID has made it a massive issue. What we've also done is that we have now collaborated with a number of other entities like HSBC, Salesforce, and formed a consortium so we could exchange best practices. And again, it doesn't address your question about medium and small enterprises. I'll take it back to my team and challenge them on it. But it is a topic of great interest for us.
Mohammed, you're next.
Thank you. I'm Mohammed Jafar from Kuwait. I'm a food manufacturer. When we're talking about health and healthcare, the food industry is responsible for quite a lot of hospital admissions because a lot of the food that is being manufactured is made to be shelf stable and cheap, but it is not healthy and it's not nutritious. We're trying to revamp this within the industry here in Davos this year, but we need help. Because basically there's no proper definition of what's a nutritious food. The focus is on saving the planet, on making foods that do not harm the planet, but the foods must not harm the consumers either. This has been lost in translation. A lot of the health systems in the United States, in India, and the UK are overwhelmed by metabolic syndrome diseases. The numbers are staggering. The profits that the food industry makes dwarfs with regards when compared to the costs. $11 trillion is the last I had heard, and the health costs are $6 trillion for industry that makes a fraction of that. Something about the system is totally broken, and so solutions. I think one matrix that we have developed is to identify what's nutritious and therefore what won't send people to hospitals is the food, does it harm your liver? Is it good for your gut? And touching on the mental health issue, is it good for your brain? And we've tried to x-ray all the products that we make to see if they respond to these three criteria. And if they don't, then how can they? And if they don't, if they cannot be made to, then should they be removed? And as we face the food crisis in Ukraine with the wheat, are we asking ourselves the question, is dwarf wheat, for example, or products associated with it good for us or not? Or are they products that actually cause metabolic syndrome? So one of the issues, I think, with climate change, for example, and where people are always asking for products that are green for the planet, we have targets to reach. In fixing the health system or in the food manufacturers' contributions to the ill health of the people who inhabit the planet, do we have metrics? And how do we get governments, policymakers to understand that the 11 trillion pot that they are spending on a regular basis and will continue to spend, they should move it, they should take that money, invest it in improving those food systems today and create foods that are healthy so that they are shelf stable, so that they are cheaper maybe, but healthy. They don't come with this burden. And I wonder if Deloitte or if in the banking community, it is possible to demonstrate, to encourage governments to basically think that way, that the money you'll be saving and from the relief from that will come to the health system is something that can be used to reinvest in revamping the food system in which we've inherited today. Thank you.
Thank you. reactions?
I don't know. Go ahead.
No, you go.
No, I didn't know if there was a question in there, but I think the point was well made. I think you said it really well at the beginning in terms of the how all of this is interrelated. So I agree with that, but I didn't get a question.
So I just wanted to add one thing. I think we all feel that labeling and then consumer power is a good thing. But labeling, and there are now movements to say, all right, food labeling has been reasonably successful. We need battery labeling. We need labeling of all sort of cradle-to-grave journey of products before we buy them. But I remember just a small anecdote. When my children were young in the US, there was a famous food pyramid that everyone was meant to follow. And now they tell us that the food pyramid was all wrong. And so, the labeling isn't always an answer, or even directives from government isn't an answer. But I think that issue of what is the role of government or business in terms of responsible food production, responsible nutrition is very important. I want to just very quickly go back to
because I want to get these two questions in.
Because I think the question about mental health was very good. I think it has to be addressed in some communities in the way that stigma was addressed around HIV/AIDS. And what we saw there was whole populations, sex workers, men who have sex with men, trans populations, wouldn't access healthcare because of the stigma. And so special healthcare workers had to be trained who are more approachable, who know better those communities, and special efforts had to be made on that. And that has made a difference where countries have implemented those systems. I think for mental health in some communities, it's going to have to be the same, special, targeted interventions.
So I'm going to come here. So there's access and equity to the final two questions. There were two gentlemen who had their hands up. Quick questions, and then, because we do need to end on time. So.
All right. I'm Bishara Shukair. I serve as the Chief Health Officer for Kaiser Permanente, and just recently served for a year as the vaccination coordinator at the White House. And the question is for you, Puneet. Obviously, and I'm also a family practice physician, but more a public health physician. And clearly, when we think about health equity, it's easier for us to get into diabetes, obesity, and all of the medical issues. But we know they're all based into fundamental practices and issues and policies and systems around housing, economic opportunity, education. And on the healthcare sector in the United States, we were able to bring about 75 or so health sectors, health businesses to put a playbook on what role can they play on the way they hire, the way they invest their money, the way they show up on housing front. What's the appetite, do you think, Puneet, for the private sector, private businesses to put together a playbook like that to address those types of issues when it comes to health equity?
And while you're thinking about the answer, let's get the other question in, and then we can have everyone make a final comment in response.
So I'll be as brief as I can. My name is George Vredenberg. I'm the chairman of a new initiative here called the Davos Alzheimer's Collaborative. And I know every one of what you're talking about has an effect on your brain health, life course. So my question is organizational. How do we get both the targeted things that we need for each of the particular problems, but at the same time aggregate our efforts to assure that we understand that this is an integrated problem?
Thank you, Puneet. Let's start with you, and then we'll go down the row, and so everyone can make a final comment.
I would say that the appetite would be high. One of the things that we did in India was create a playbook, made it available to all districts in India. So I think it would be high, and I think it would be high even in terms of getting a consortium of private sector players to collaborate with public entities to address particular issues. The one thing that I would say is that the problems are many, and to try and target them down, but the point made that they're all interrelated is an important one. But I think that it would be a good appetite for that.
Carolyn?
So I would say that if public health is the bedrock of economies, if that's what COVID has taught us, we now have to put in place a system that actually supports that. And that means international institutions have to look at the debt issue, protecting health spending. Governments have to now look at how they can empower capacity development to give health systems at the local level. The private sector has to take a responsibility for their supply chain, all along the supply chain, and civil society has to hold people accountable for doing this with data systems that would allow people to track. Then we might have a system which actually recognizes that health is the bedrock of our economies.
Thank you. Mats.
Yeah, just a quick comment. When you look at a chronic condition like obesity, I would just echo what you said about stigmatization, because only 32% of Americans who have a BMI above 30 are informed that they are obese by their practitioner. And until you actually are able to have an unstigmatized dialogue about things, nothing will happen. So we also need to work with the media, with the social sciences, humanities, and so on to destigmatize.
Thank you. Tolu.
Thank you. And I'll end with 3 calls to action. The first is around the need for commitment to design and financing health into these infrastructures. So we need to think differently about health infrastructure. I call health infrastructure the people that I call transport health infrastructure. I call housing health infrastructure. So we've actually got a session, you talk about a playbook and a consortium. I've got a multilateral today looking at getting people, organizations who are financing or designing urban infrastructure projects to look at making health generating principles. So if you're interested in that from the private sector, do come to me. So that's the first thing, making those commitments. The second is around thinking about how we generate evidence. So integrating health and disease and health data, thinking differently about who is a health practitioner. You're a health practitioner. You're a health practitioner. You're a health practitioner, right? In terms of what we do. And the third final thing is the importance of enfranchising citizens. So a lot of the approach that I take, so because my work is largely on the African continent, which is the largest growing and the youngest continent. If we're not working with young people, I don't know who we're working with. I don't actually like the word young people because it implies a niche group. But when the majority, when 65% of your population is under 25, it's just the majority demographic. So some of the work that we're doing is saying, how do we work to even the data collection? How do we adopt participatory approaches to ensure that we're working with the beneficiaries as well as the change agents to build these systems that are inclusive and healthy?
Thank you. Yeah. So I'm going to sum up very briefly. This is a whole of society question, and it's a whole person question. If we think about things in that way, we'll make more progress. Don't hesitate to ask the forum team who's here if you want to learn more about the Global Health Equity Network. And now let's just thank our great panelists for some great insights. Thank you.